Good evening. My name's James Stanger, and a cold, wet Australia's winter's evening. I'd like to talk about a recent publication looking at the instance where you have lots and lots of euploid embryos, and what's your chance of pregnancy when these are all transferred back. So the title of this talk is Six of the Best, as Good as It Gets, and I reckon that's pretty true. This paper is not an open access one, so I can only provide data from the abstract from an American group published in Fertility and Sterility 2 or 3 days ago. And just as a break, I've introduced this advertising thing for my videos. It's just a very quick one. If you'd like to promote your product or your clinic or anything, any other information, contact FirtAid and we can put your contact details on this notice board. Anyway, enough of all that. Cumulative probability of a live birth after 6 sequential single euploid embryo transfers. It sounds like an awful lot of embryo transfers, but look what data they got from it. The conclusion: continued sequential transfer of euploid embryos is supported as a primary management strategy after early transfer failure. In other words, if the first embryo transfer doesn't work, keep going because the results are there. And this data is actually quite pretty impressive. For patients able to generate an adequate euploid embryo inventory, aligned with their individual risk tolerance, persistence with treatment is associated with a high likelihood of achieving a live birth. And often in IVF, our counsellor always used to say, you don't keep encouraging people to have a go, they should stop and reassess their values. But a lot of us in the lab will say, just keep going because the embryos will always give you a pregnancy at some time or other. And this paper kind of supports it. So continued sequential transfer euploid embryos is supported as a primary management strategy after early transfer failure. There is also this other concept after a couple of transfers, if you haven't had pregnancy, then you have spontaneous implantation failure. And a lot of people will stop at that time and maybe go back and do another pickup, leave some embryos in the freezer and go back and collect a whole new cohort of embryos. And this has led to the concept of recurrent embryo failure, but a paper published in 2024 by an Italian group. So in this one, they said, what's already known, the first three euploid blastocyst transfers have similar implantation and live birth rates and provide a cumulative birth rate of about 92.6%. But if there's a fourth and fifth embryo to transfer, then the argument in this paper is the fourth and fifth euploid transfers resulted in a similar live birth rates of 40 to 50%, respectively, culminating in a cumulative live birth rate of 98.1%. That's almost 100%. That is the holy grail of IVF after 5 euploid blastocyst transfers. So what happens when you have lots and lots of euploid embryos to transfer? Some have suggested after 2 or 3 failed transfers may be defined as recurrent implantation failure, and they will basically just discard the remaining embryos or just ignore them. They would consider they are not suitable and presumably do some sort of investigative work or most likely just do another IVF cycle. But this paper suggests that even after 4 or 5 transfers of euploid embryos, the birth rates were similar and therefore questioning whether recurrent implantation failure really actually exists. So the aim of this particular paper was to go one step further, to go to 6 embryo transfers, to basically is to confirm that previous observation that 4, 5, or 6 transfers of euploid embryos gives you roughly the same pregnancy rate per transfer. It doesn't fall off. And we'll talk a bit more about that at the end. So if you persevere, you can get to the end of the video where I have some comments to make. So the object of this paper is to estimate the cumulative probability of achieving at least one live birth after up to 6 sequential single euploid transfers and to characterize the post-transfer outcomes to inform evidence-based counseling for patients undergoing IVF with pre-implantation genetic testing for aneuploidy PGT-A. The design was a retrospective study in a university fertility center. Patients who underwent IVF and PGT followed by euploid transfers over the 10-year period of 2014 to 2024 and they needed to have up to 6 sequential transfers until live birth was achieved or the patient discontinued additional transfers. So the mean age was 36. Now, I thought this was interesting. When I first thought about the paper, I would have thought the average age getting 6 euploid transfers would have been in the late 20s or very early 30s. But these are patients who are 36, average 36 years old, and they're having sufficient number of embryos to give you 6 euploid embryos after transfer. That is, if the euploid rate's only 40%, if they have 6 euploid embryos, that must mean they have roughly 12 or 13 or 15 embryos to biopsy. In fact, I haven't talked about that in this video, but I might come back to it if I remember. So the odds of transferring a day 6 or a day 7 blastocyst versus day 5 were higher as you go on. So in other words, the first embryo is nearly always a day 5 embryo. That is the best. But a lot of clinics allow blastocysts, if they're not quite fully expanded, to grow another day. And if they are suitable if they are forming a blastocyst on day 6 or day 7, they will be frozen. And usually they're the last ones to be thawed and transferred. Therefore, you may have a reasonable expectation that the pregnancy rate will fall with multiple transfers. And this is one reason why a lot of clinics stop. And this data suggests that's not true. So this data can only come from the abstract because you can't read the paper because it's not open access, which is a shame because I think this is a very good paper. The data is really spectacular. And it's a shame that it's not open access. So amongst 5,800 patients undergoing 7,763 euploid transfers, the estimated cumulative probability of live birth increased from 63% after the first transfer and then to 98.3% after 3 transfers and 98.8% after 6. Well, there's not much difference between 4, 5, and 6. The pre-transfer live birth rate declined from 63 to 54% second and then remained stable. So the first transfer, it has the very best, almost always best quality and a day 5 blastocyst. But after that, the quality of blastocysts seem to be fairly uniform. And there's a lot to actually think about this paper. The rates of spontaneous abortion, biochemical pregnancy rate, and non-pregnancy followed a similar trend. Fewer than 5% of patients met the criteria for recurrent implantation failure after 3 transfers, and fewer than 2% remained without a live birth after 5 transfers. So, the conclusion, continued sequential transfer of euploid embryos is supported as the primary management strategy after early transfer failure. So the strategy is keep going. The strategy is put all your embryos back and don't stop. Just keep going. For patients able to generate an adequate euploid embryo inventory aligned with their individual risk tolerance, persistence for treatment is associated with a high likelihood of achieving a live birth. Now, this table, I was able to see a journal pre-proof of the paper, which was available online. And I actually don't know whether this will actually still be available, even though it was not an open access paper. But I'll put it in anyway, and if everything is wrong, then I'll just delete the whole video. But look at this data. If you're an embryologist, a doctor, or a client, this is really groovy stuff. You start with 5,800 patients, and on their first transfer, look at this, 3,664 had a baby, a live birth. 63%. That really is quite impressive. It's similar to a lot of them. Remember, these women are on average 36, so some will be a bit older than that. Then the interesting thing that happens after this one, look at this. 744 people never came back. They left all these embryos in. Oh, actually, I don't know how many embryos they had. This paper's a bit unclear, but like 35% of people never came back. What sort of? I just don't understand how people can walk away having collected all these embryos and not been pregnant and then not come back. It's such a waste. But the second set of 1,400 clients, 54% are pregnant. And as I said, there's a lot more day 6 and day 7 embryos here. But once again, you have a 40% people dropping out. I think actually this needs a study. So why do people drop out when they have embryos in transfer? Third set, pregnancy rate 54% down to 300. Look at this. You start with 5,800, and after 2 transfers, you only have 390, roughly 400 patients left that are not pregnant. That's, yeah, I can't, a lot of those haven't turned up. 54%, 50%, 50% after 5 embryo transfers, and it's a bit different on the sixth one, but only 7 cases. But interesting, the dropout rate is the same. In fact, that is actually the more interesting thing with the paper than the pregnancy rate. Okay, this table was publicly available on the pre-proof version of the paper. The first point is the vast majority of clients were pregnant after their first and second transfer. About 33% of cases did not return on second and subsequent transfers, but I couldn't see anywhere in the paper, in the pre-proof paper, why. But remember, these women are 36. I think this is really quite an impressive set data. I think the clinic should be congratulated on that. But the interesting thing about getting 6 euploid embryos is that, as I said, on average, 40% of embryos are euploid, 56% are aneuploid and discarded, and 10% can be mosaic, which are now called euploid because they slow babies. But you have to ask the question, how many embryos you have to get, how many eggs you have to collect and make into embryos to get 6 euploid embryos after they've all been biopsied. And this paper from Hawaiian group actually gave you the insight here. This paper said they investigated the distribution of euploid embryos between cohorts as predicted, and they concluded the probability distribution structure of euploid within a discrete cohort size is binomial. That is, it's either yes or no, and it's fairly linear. I'll just show you the graphs. So these are 30, 34, 35 to 37, 38 to 40, 41 to 42. And basically, the number of euploid embryos gets smaller as you get older. This is why this data is so impressive, because these people had 6, and this is this group up here that had 6 euploid. So if you're under 30, the incidence of euploid embryos is almost 1 in 2. And it's almost a 1-to-1. But as you have an older group, the incidence starts to fall away a little bit. But even so, if you wanted to get 6 euploid blastocysts, you need at least 10 or more embryos. And so the probability that a blastocyst or euploid decreases with maternal age, but increases with cohort size within the 6 separate stratified groups. So they concluded that the number of euploid blastocysts is roughly linear to the blastocyst count. So as you have more and more blastocysts, the proportion of those that will be euploid are fairly consistently at 40%. This is a largely age-related thing, with older women having fewer euploid embryos than younger women. So the rate decreases as you get older, but it's still a relatively linear progression. So for if you're under 30, it might be close to 1-to-1, but maybe for 40-year-old women, it might be 1 in 4, but it's always 1 in 4, regardless of how many oocytes or embryos you make. So my comments, this is probably a bit of a rambling video, I do apologize, but I thought this was a really good paper. This is as good as it gets. I think this is a good paper. I actually said great here, didn't I? While few clients will generate sufficient embryos to cryostore 6 euploid embryos, the similar live birth rate from the first to 6 transfers suggests that the concept of recurrent implantation failure after 3 transfers may no longer be valid. Rather, implantation failure may reflect embryo quality rather than or uterine refractiveness. The data also suggests that the success of individual euploid embryos is also influenced by intrinsic embryonic and patient-specific factors. So for whatever reason, putting a euploid embryo back that's fit and healthy will consistently give you 6 out of 10 implantations. But it's very hard to get more than 6. There's always something happening here. And I actually think it happens back at the fertilization step rather than anything else. Indeed, the data is reminiscent of the original pregnancy rate for young couples trying to conceive, and often takes 6 months to reach a 90-95% pregnancy rate. It also provides a powerful target for clinics to aim for, 6 euploid transfers. So if you're going through IVF, part of your counselling process should be how many embryos, how many transfers should I have? And this data suggests that it's worthwhile continuing, because you will get almost everyone pregnant if you put back those 6 embryos. Granted, the last one's a bit, there's still 2 pregnancies in that group of 7. And so there's a really good chance that if you have 6 embryos, you put them all back, you will have a baby. and you're more likely to come back and have a second baby or a third baby from the thyroid residual. So the people, just on that point, we often talk about an IVF about pregnancy rate per person, but in reality, if you ask a couple how many babies they want, they have a fairly clear idea of what will constitute their family, and it usually is relates to the number of siblings they have. So if you have six blastocysts, six euploid blastocysts, you put the first one back, and two-thirds of those are pregnant, then you know you have a fair degree of confidence those remaining five embryos, euploid embryos in storage, will give that couple a really good chance of having a second, a third, or a fourth child if that's their wish. And I think I think counsellors need to be aware of this paper and advise couples accordingly. And so it also supports the above data suggesting that the incidence of euploid per follicle and per egg and per embryo is sort of constant for any specific age group. And there's the more follicles you recruit, the more euploid embryos one may expect. Okay, I think I'm rambling a bit here. I'm going to stop. My name's James Danger. I'm an embryologist with my 50 years experience. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor and maybe help you understand the advice you receive. If you like what I'm doing, press subscribe and select like and make a comment, actually. A comment would be good. This clinic is paid for by my fertaid.com YouTube, fertaid.com EQA program, which is a training program, and an EQA program for IVF for andrology and embryology. Okay, I'd like to thank you. I know IVF is a personal journey that involves the action of many techniques, ideas, staff, etc., and it helps to understand all aspects of that journey. I hope this information has been of value. If you like what I'm doing, please tell others and please press subscribe. I'll say good night.